Today, I'm going to talk about feedback, how to give it, and how to receive it. This video will apply most directly to the world of academic medicine, but a lot of principles will be relevant in other fields as well. Throughout this video, I'll be referring to the two halves of the feedback partnership as teacher and learner, keeping in mind that those specific labels may not apply perfectly in every situation in which feedback is occurring. In the first part of the video, I'll be discussing giving and receiving feedback in the abstract, and in the second part, I'll be demonstrating what this looks like in practice. To get us started, what is meant by the word feedback? Feedback is specific information provided to an individual that compares their performance to a standard with the goal of encouraging improvement rather than providing a formal assessment. Feedback can take many different forms, some of which are more obvious than others. It can occur within a dedicated one-on-one conversation between teacher and learner, in which case the feedback can be focused on something as specific as a single oral presentation, or on something as broad as performance during an entire month-long clerkship. Feedback can occur after something called an objective structured clinical examination, or OSCE. Feedback can come from written comments provided at the end of a course, clerkship, or clinical rotation. It can come in the form of anonymously written peer surveys. But feedback can also be much more informal. This includes brief, real-time, offhand comments that one could easily miss as being feedback, and even nonverbal cues from the teachers directly observing a learner, such as facial expressions, in response to the learner's actions. Not to state the obvious, but not all feedback is equally helpful. In fact, some feedback may be inadvertently harmful, particularly if excessive, or if it appears to attack the learner's identity. Instead, what characteristics should feedback have? It should be specific. Telling a learner that they did a great job or a terrible job and leaving it at that is not helpful, nor is feedback that the learner can read more. Versus the teacher providing the learner the feedback that during oral presentations, the learner appeared to have knowledge gaps regarding treatment for their patient's primary diagnosis, which could be rectified by reading a review article on the diagnosis the night before. That is much more specific than just read more. Feedback should also be actionable, meaning that the learner should be able to quickly adjust in response to it. So telling an intern that patients have trouble understanding them because of a thick accent, even if true, is not helpful. Versus, for a different intern, if their patients have trouble understanding them because they speak too quickly, that is helpful to point out because it is much easier to address. Feedback should be timely. If, as a teacher, you observe a learner do something incorrect, if you wait 4 weeks to point it out, the learner may have forgotten the details of the event that you observed, and you've also wasted 4 weeks during which the learner could have been working to improve on whatever was observed. Feedback should be tailored to the learner's stage of training. If you are observing a very early learner, such as a first-year student, and you focus on minutia, or you give them a seemingly endless laundry list of perceived flaws in performance, the learner is going to disengage. When I work with second-year students on oral presentations and written notes, I tell them right up front that the volume of feedback I will be giving them in response to individual encounters will be roughly constant throughout the year. That does not mean they aren't improving, but rather it means that as they improve, the feedback I'll be giving them will be incrementally more nuanced. And lastly, feedback should be inclusive of the learner's own goals. That does not mean that you only need to address the learner's own goals because the learner's goals may not be well matched to the expectations of the course or program that they're in. But if none of your feedback hits on what the learner feels is most important to them, once again, the learner will disengage. Now let's get a little more specific with the process of giving feedback, and the first step is to set it up. That starts before whatever experience will serve as the basis for the feedback. So when possible, the teacher should inform the learner of the intention to provide feedback in response to an upcoming encounter or experience. The teacher will want to avoid feedback catching the learner off guard. As part of the process of giving them a heads up, time permitting, the learner should also be asked for their own goals prior to the observed experience. That way, the teacher's observations can be preferentially focused on behaviors that are related to those goals. After the experience has occurred, if the feedback will be verbal, the teacher should optimize the feedback environment. The conversation should occur in relative privacy and with limited distractions. The learner should be mentally prepared to receive feedback. So if an encounter went unusually poorly and the learner seems visibly flustered, that may not be the best time to talk about how it went. Depending on circumstances, the learner may need 5 minutes or an hour or even a day before they're ready to discuss it with their teacher. And lastly, the teacher should ensure that it's clear that feedback is about to be provided. Some learners will not realize that brief informal comments on the fly while on the wards are intended as feedback. So even if it's just a brief moment about something relatively minor, I still recommend literally always using the word feedback. In situations in which the teacher and learner are able to have a structured sit-down conversation for feedback, there are several models to its potential organization. One which I think works well is called Ask, Respond, Tell. This model starts off with a teacher asking the learner how they did. How do you think that went? Did you meet your goals? In other words, the learner provides a self-assessment. Next, the teacher directly responds to the learner's self-assessment. And last, the teacher tells the learner about any additional observations not covered in the self-assessment. Within the Tell section, another model that comes into play is called Keep, Stop, Start, which the keeps are things which the learner did well and which they should keep doing. This is reinforcing feedback. The stops are things that the learner did which they should stop doing. This is called corrective feedback. And the starts are things which the learner did not do but which they should consider doing in the future. A slightly different alternative to Keep, Stop, Start is referred to as the feedback sandwich, in which you start with reinforcing feedback, which is often framed as positive feedback, then some corrective feedback, often framed as negative feedback, and then you close with some more reinforcing feedback to end the discussion on a positive note. What are some pitfalls when giving feedback? Some of these have already been alluded to. Not starting with a learner's self-assessment. The feedback is too vague. The feedback is excessive in its volume, or it's too advanced for the learner. The feedback is not actionable or is focused on an attribute of the learner rather than on a behavior. And possibly the most frustrating of these for the learner is when there is inconsistency between timely verbal feedback and delayed written feedback. For example, if a med student is taking a 4-week clerkship and all the real-time verbal feedback they receive while on the wards is all glowing, and yet the written feedback that comes 2 to 3 weeks after the clerkship is over is full of negative feedback, that's super frustrating for students, so please don't do that to them. Giving feedback summarized. Assess learner goals beforehand. Optimize the feedback environment. The feedback itself should be structured according to the Ask, Respond, Tell model, in which the Tell portion follows either Keep, Stop, Start or the feedback sandwich. And last, at the very end, the learner should be provided opportunity for questions and comments. Now, let's briefly look at feedback from the perspective of the learner. After receiving feedback, the learner should first thank the teacher for it, and then reflect on it. As the learner, do you agree? If not, why not? And if you do agree, how should you alter behavior to reflect the feedback? There are also pitfalls when receiving feedback. For example, not proactively seeking it out, or only seeking the positive reinforcing feedback. Reacting defensively, misinterpreting respectful corrective feedback as an attack on character or identity, which is tricky because some poorly delivered feedback actually can be an attack on character or identity. discounting corrective feedback because of the manner in which it was given. Just because feedback was given using harsh language or in a non-private environment or in a way that just didn't make you feel good, it doesn't mean the feedback was necessarily wrong. Not reflecting on the feedback given, no learner will agree with every piece of feedback they ever receive. There was certainly corrective feedback that I received as a student that I thought was unfair or was inaccurate. It's okay to disagree with feedback you've been given, but it's not okay to reject it reflexively without consideration. And last, not incorporating feedback into changed behavior. Once again, it's okay if you as a learner disagree, and if that's the case, you don't need to make any permanent long-lasting change to what you're doing. But if you're going to work with that same teacher again, the one who gave you the feedback you disagree with, and the teacher will expect for you to have changed in response to that feedback, you should at least consider whether you should temporarily adjust the way you do things just when being observed by that particular teacher. Okay, at this point, I'm going to demonstrate what feedback might look like in practice. The scenario: Dr. Strong is the attending physician on the internal medicine ward. He's working with a medical student, Eric, who has just been asked by his resident to take an H&P on a newly admitted patient presenting with acute dyspnea. Eric, I understand our resident has asked you to see the new admission and perform a history and physical. I'd like to observe you and give you some feedback afterwards, if that would be okay. Sure, Dr. Strong, that would be great, thanks. Before we go into the room, do you have any goals for the encounter regarding your own performance? Yeah, of course. First, I want to establish good rapport with the patient and make the interview feel natural and conversational. And something else I've been trying to improve on is doing an appropriately focused physical exam based on the history, rather than just running through the same long list of maneuvers that we learned in our physical exam course last year. Those goals sound great. Let's head in. I'll let you introduce me after you've introduced yourself, and I'll otherwise try to stand back and just be a fly on the wall. Okay, Eric, how do you think that went? I think it was pretty good, but not perfect. Tell me more about that. Things started off well. My introduction was solid, and I initially tried to keep the questions open-ended. There was, I think there's some good rapport building, especially during the social history when we were talking about her kids. But by the end, it always feels like I'm running through a checklist that feels kind of distancing with the patient. Why do you think that is? Probably because the review systems is so long. I agree. The review systems part of the encounter feels like a checklist because it is a checklist. So how can we improve on that? I don't know. Have you yourself seen a clinician for an urgent medical problem before? Well, yeah, sure. So how was that different? Did they run through a checklist of questions like you just did in the room? I don't actually remember there being much of a review of systems at all, to be honest. Precisely. Experienced clinicians avoid the sense of going through a long checklist of questions by not doing it. If an ROS question is relevant to the chief complaint, it should be included during the history of present illness. If an ROS question is relevant to one of the patient's chronic medical conditions, it should be asked about during the so-called past medical history section. And ROS questions which are not relevant to either, they don't need to be included. The model of asking a thorough 14-system ROS is outdated and no longer recommended. Thanks, I didn't know that. One of your other goals was to focus the physical exam based on the history. How do you think you did with that? I think I did well with that. By the end of the history, my differential diagnosis was primarily acute heart failure versus pneumonia versus pulmonary embolism. And I feel like I did a thorough cardiovascular and pulmonary exam, including assessing for JVP, and I felt for nodes in the neck and the axillae that could be related to a potential infection. And I chose to only do a limited HENT and abdominal exam because those parts of the exam just didn't feel quite as relevant. I agree that you did a good job focusing the exam for the reasons you've mentioned. But given that your differential included both heart failure and a PE, Is there anything you think you might have forgotten, say, in the lower half of the body? Checking for edema. Yep. Sorry, Dr. Strong. I'll go back and check as soon as we're done talking. That sounds like a good idea. Overall, I think you have an accurate self-assessment, but I'd like to discuss a few things that I observed in addition to what you've already mentioned. First, I appreciated the use of the patient's name throughout the interview, which was just the right amount to make it not seem like you were going out of your way to do that. And I also liked how you explored how the patient's dyspnea was impacting their life and what they were worried about. When it came to the exam, I liked your technique of checking the nodes. It felt like it was smooth and thorough and had been, practiced many times. I also liked how you seemed to be really listening closely during cardiac auscultation by spending a good amount of time with the stethoscope on the chest. I know that it can seem awkward to sit there in silence while you're listening, but that's really what you need to do in order to not miss subtle sounds like an S3, which would be relevant in this particular patient's case. So I was very happy to see you do that. Now, I do have two stops for you. First, I noticed a piece of medical jargon that I'm not sure the patient understood properly. Can you think of when that might have been? When I asked if they were experiencing any palpitations? Yes, that was it. While some patients understand palpitations, not all patients do. So instead of asking, have you noticed any palpitations? I recommend asking, have you noticed any times when your heart was beating unusually quickly or prominently, or felt like it was irregular or skipping beats? Another stop was telling the patient after every single exam maneuver that maneuver had findings were healthy and normal. Now, I know that you're trying to practice what you learned in pre-clin, but it does start to feel a bit repetitive, and it isn't necessary. So instead, I'd just summarize the exam either at the very end or after each large section of the exam. And regarding a start, I did have one. Did you notice how the patient had to keep straining their neck to face you? I should have sat down. There was a chair that was right there, and I didn't say anything because I wanted to see if you'd realize it before the end of the encounter. But it's really not a big deal. But aside from making the patient and yourself more physically comfortable, it is believed that patients' perception of how much time we spend at the bedside with them can be positively influenced by sitting. Thank you for pointing that out. I'll remember that for next time. Eric, overall, I think it was a very solid job, and I look forward to hearing your oral presentation on the patient during rounds tomorrow. Do you have any questions or other thoughts? No, I don't think so, but thanks again for the feedback, Dr. Strong. I really appreciate it.